extremely important to use the microbiology help in managing the critical care infections. It could be useful if you interpret very appropriately and use the knowledge in managing infections. But I think it is also important not to use the test when they are really not needed. So Dr. Kamila, I want to ask you, what are the real indications as of today of procalcitonin in managing infection?
Actually, to be honest, we've not found too much of joy in using procalcitonin in diagnosing sepsis. If anything, we would use it to de-escalate and not to diagnose. Because though traditionally procalcitonin has been defined at set concentrations to say that this patient has a bacterial infection, we've often found some amount of cross-reactivity. It may take time, and we believe it's, if any indication, it should be used for de-escalation.
You know, even the surviving sepsis guideline also says that this is a test which should be used for discontinuation rather than as a guide to start antibiotics. Then the other thing is that whenever you have a patient and you get an antibiogram, and looking at the antibiogram, can a clinician find out what could be the possible mechanism of resistance and which can help him in choosing the antibiotics?
Actually, I just showed you, from the susceptibility pattern, you can make a calculated guess as to whether it would be, say, ESBL, whether it would be AMP-C, or whether it would be, say, carbapenemase. And I think at this point, I made that point in the talk that carbapenemases which are hitting us badly, at least in India, the difference in the literature that's coming out from the West are essentially to do with KPC, which are serine carbapenemases, and they are more susceptible to gentamicin. They are more susceptible to beta-lactam inhibitor combinations than the metallo, which we have, the NDMs, which are resistant with the 16S methylase, resistant to the aminoglycosides, and no beta-lactam inhibitor combination seems to help currently now. So the mechanism of action, yes, you can to a certain extent make a calculated guess on whether it is a ESBL. If all third and fourth generation cephalosporins have gone, it's usually an ESBL. If BL, BLI have gone, then it's usually an AMP-C.
The other thing is, many a times the report comes like a urine culture and the organism grown is Acinetobacter, sensitive to TG cycline. So what do you think? Is there an importance for the person who is interpreting to have an eye on whether that drug penetrates to that site of infection where you are thinking the infection is present at that point of time?
I think that's really important because, for example, tigecycline would not be useful in UTI, shouldn't be reported. Similarly, cefazolin would not be useful in meningitis, should not be reported. Similarly, chloramphenicol, not useful in UTI at all. Moxifloxacin, not useful in UTI because these drugs are not active at that site. And I think microbiologists should make a call or put a star and say that if this is from this site and despite the susceptibility, advise not to be used.
And in the current setting, what do you think is the most important thing in interpreting antibiogram? You think that every lab should report MIC and breakpoint and a clinician should ask the microbiologist to report these?
Difficult question. I think as far as intensive care is concerned, yes, we should be reporting MICs because the information is more accurate, it's far more accurate in seriously ill patients, and I think for intensive care we should be reporting MICs. Though having said that, in a routine care on the floors, maybe disc diffusion is okay, especially for urinary tract infections where perhaps it's a little bit more expensive to do MICs, but intensive care I think MICs are required.
So I think for managing patient appropriately you require the help of microbiology, but then I think you should, in consultation with your microbiologist, try to keep on improving the lab and have, if it is not available with you, to have an MIC and breakpoints to manage your patient appropriately. Thank you very much.